Hi there, my name is Mateo Espinosa, and for my Global Environmental Health class at NYU, I will be discussing the topic of the cholera disease. The purpose of this project is to determine where cholera comes from, who it affects the most, and if there are any preventable measures found within our world today. We will start off with the history of cholera, which will basically be a timeline of the disease. Secondly, we will find out where cholera is found today. We will then look and see if there are any demographics of the disease, when we will focus on a more comprehensive study done in Sierra Leone at this point. We will also look at any cures and preventions, and we will also see the worldwide case count over the years. We will then finalize with a summary and see what we have learned. Although it is unclear when exactly cholera first affected people, some say that we can trace it all the way back to the 4th century BC, where Hippocrates first described isolated cases in Greece of cholera-like illnesses. However, we will focus more on clearly recorded cases, starting with the first cholera pandemic. In Figure 1, we can see the table discussing this history. The first cholera pandemic emerged out of the Ganges Delta with an outbreak in Jessore, India in 1817, stemming from contaminated rice. Although it started in Southern Asia, it also spread beyond. In 1821, British troops traveling from India to Oman brought cholera to the Persian Gulf. The disease eventually made its way to European territory, reaching modern-day Turkey, Syria, and southern Russia. The first pandemic died out after 6 years that it began, likely thanks to a severe winter. The first pandemic is said to have caused 2.7 million deaths. The second cholera pandemic began around 1829. Like the one that came before it, the second pandemic is thought to have originated in India and spread along trade and military routes to Eastern and Central Asia and the Middle East. By 1833, it had made its way to Northern, Central, and South America, causing a total of 250,000 deaths in 2 decades. Between 1852 and 1923, the world would see 4 more cholera pandemics. However, in between then, we were able to determine the source of cholera. In 1854, Great Britain saw one of its worst cholera outbreaks yet, killing 23,000 people alone. In that year, British physician John Snow, who you may also know is considered one of the fathers of modern epidemiology, carefully mapped cholera cases in the Soho area of London, allowing him to identify the source of the disease in the area, which happened to be contaminated water from a public well pump. He convinced officials to remove the pump handle, and which immediately dropped the cholera cases in the area. He then also convinced the city to filter said water through sand, a method still proving effective today. In 1883, we were also able to understand cholera to a greater extent. German microbiologist Robert Koch, the founder of modern bacteriology, studied cholera in Egypt and Calcutta. He developed a technique allowing him to grow and describe the V. cholerae, and then was able to show that the presence of the bacterium is within the intestines that caused cholera. The 6th cholera pandemic, which happened between the years 1899 and 1923, largely didn't affect Western Europe and North America due to the advances in public health and sanitation. But the disease still ravaged India, Russia, the Middle East, and Northern Africa. The 1923 cholera cases had dissipated throughout much of the world except India. It killed more than 500,000 people in India in both 1918 and 1919. When we look at cholera today, we can see that it has been eradicated or largely contained in many parts of the world. It is, however, still present in many countries that do not have controlled or clean water supply systems within. In Figure 2, we can see a map taken from the WHO Gamma Map server that shows those countries most affected in the year 2016. Here we can see that cholera is still highly present in the Middle and Eastern Africa. In 2016, the country with the highest case count was that of the Democratic Republic of Congo, with a total of 28,000 cases. The following countries were Yemen and Somalia, with over 15,000 cases each, both of which had large epidemics at the time. Our next slide delves into the demographic and social determinants of health of cholera. One might believe that a disease like cholera is not particular to any group of people, and in most cases, this is true. Across the global spectrum of the disease, it's quite clear to state that those who fall under the poverty line and don't have access to clean drinking water are more likely to get cholera. However, there have been recent studies that state that women in these social classes are even more likely to get the disease than men are. As mentioned, cholera is transmitted principally through contaminated water and food. This means that everyone, men, women, boys, and girls, are vulnerable to infection. However, as we can see, women and girls have a heightened risk of coming into contact with a high infectious dose of cholera. This is assumed to be the case due to their domestic roles taking care of sick family members, cleaning latrines, fetching and handling untreated water, and preparing contaminated raw food. As a result, there appears to be an excess disease burden among women and school-aged girls. When looking specifically at the study done in Sierra Leone in this graph in figure 3, the higher incidence of disease among girls and young women aged 5 to 24 may partly reflect aspects of vulnerability that relate to gender roles and health statuses, such as caretaking of babies and small children and reduced immunity during pregnancy. Not only in Sierra Leone, but in other African and Central American countries, girls are often groomed from a young age to take care of babies and young children. If the infant is infected with cholera, then young girls who clean and feed the child are likely to contract the disease themselves. While no studies in the international literature have explicitly presented a gender analysis of cholera epidemic, data from several studies nonetheless support this idea. Now we will look at the prevention and treatments that exist today. Many think that the prevention of cholera would be easily attainable if a clean water supply could be provided within individual communities that deal with constant outbreaks. However, there are many more aspects that come into play when it comes to treatment and overall prevention of this disease. After having done some research on the WHO and Global Task Force on Cholera Control Sites, there are 6 main areas that need to be targeted within said communities in order to implement a sustainable change: water, sanitation and hygiene, leadership and coordination, strengthening healthcare systems, surveillance and reporting, oral cholera vaccines, and community engagement. These 6 areas are condensed into 5 research and implementation projects at the Global Task Force on Cholera Control, and the following pie chart shows which of these projects are currently more funded and in progress. Epidemiology and laboratory surveillance and reporting projects are the highest initiatives being researched and developed throughout the world, with 29%. The second and third projects are water, sanitation, and hygiene with 24%, and oral cholera vaccines implementation with 22%. We will discuss what this means a little more during the summary. Lastly, in figure 5, we can look at the recent worldwide case count between the years 2000 and 2020. Although the cholera count has been low for the majority of the 21st century, there have been some noticeable peaks in the last decade. In 2011, there was a high cholera outbreak in Haiti with 325,000 cases. The large outbreak and lack of control has been attributed to the 2010 earthquake that the nation faced and is still recuperating from to this day. We can also see an increase in cases between 2016 and 2018, which is due to an epidemic that spread among settlements along the Nile River. 2 other large outbreaks occurred similarly in 2017 in Zambia as well as Yemen. These numbers are quite large if we look at them in the span of the past 20 years. However, if we compare these numbers to a decade ago, the worldwide count averaged around 15 million in the 1920s. So, what have we learned? Well, first and foremost, we can recognize that the cholera outbreak dates to the early 19th century in South Asia, more specifically India. Secondly, we know that the source was determined by John Snow in 1854 by contaminated water. And although it is mostly eradicated in the world, it is still found to a great extent in Eastern Africa. While there is no explicit gender analysis of the cholera epidemic, it is mostly seen in women between the ages of 15 and 24 due to the household discrepancies that exist. And as mentioned, the projects that are more and then finally, something that is most important to realize is that prevention and treatment is possible. As mentioned, the projects that are mostly researched in cholera prevention are those of epidemiology and laboratory surveillance, water, sanitation and hygiene, and cholera vaccine implementation. Although this is a great success for the eradication of the disease, there is an urgent need for leadership and coordination within individual communities. Strengthening healthcare systems through funding and increasing community engagement is something that needs to be addressed in order to increase the knowledge of what cholera is and how it can be further prevented. Thank you so much.